to every attending today. As you just heard, this will be recorded for folks who are missing it. Reminder that members of the public are absolutely welcome to observe and to provide comment during the public comment period at the end of the meeting, but discussion is reserved for board members. So let's get started with roll call. I will say before we set this roll call, we realize we have a small group today, but this is informational and will be recorded for any members who can get it started.
Okay, I will call your name. Please let us know if you're here. April Roman. Adria Decker. John McElveen.
Present.
Tammy Kane Suleiman. Annalise Dolph.
Here.
Zeb Payne. Nick Ocone.
Here.
Lori Trieger.
Here.
Skylar Brocker Knapp. Joanne Linville.
Here.
Julia Hyduke. Carrie Brajati.
Here.
Rick Trelevin.
Here.
Fernando Pena. We have a new board member who will be arriving at 11, Sheriff Matt Phillips. Annalise will introduce him when he gets here. Representative Hai Pham. I see he has a staff member attending. Senator Lou Frederick. Judge Alicia Edgeworth Kersey. Roll call is complete.
And I'll just note that April just joined. And did somebody else just join as well?
Julia.
Julia, okay.
Okay, well, let's get started and we'll try and take note as folks join and give Sheriff Phillips a chance to introduce himself later. As members know, we're going to be gathering in January to look back on our work together over the past 2 years and plan for how we are going to allocate funds.
Hey, Annalise, we can barely hear you.
Oh.
Is that better? Okay.
Yeah.
Always changing locations. So we'll be gathering in January to discuss the next round of funding. So the plan is to use today and our meeting in December to hear from grantees, existing grantees in each of the categories we allocated funding to in 2023 to 25. Today we'll start with presentations from grantees in the prevention, treatment, and recovery categories. And we will talk about the January retreat as well. Next slide. Okay, so here's our agenda for today. I think Adria is not with us today, so I think we're going straight to fiscal update from Tammy. Lisa will share some brief program highlights, but we'll spend less time than usual since we're hearing from grantees later today. Alexis Cook from Comagine is going to do a quick review of the revised quality improvement assessment. Zach from PRR will share an update on the work of the Research Evaluation and Data Subcommittee. And then we'll hear from our grantees. Very exciting. Starting with Mackenzie Bullard, sharing some background about the Focus Grant program, and Raven Lopez from Todos Juntos speaking to primary prevention work in the school system. Michelle will give us an overview of treatment, and Dan Hoover, Dr. Hoover, will be here to talk about the MOUD and jails technical assistance. We'll have a quick break and then come back and hear about the recovery funding category from Michelle and hear specifically from Oxford House and True Colors. And then we'll talk about the retreat and we will wrap up for the day. So that is our agenda. We don't have, as I mentioned earlier, we don't have any votes today, but we do always post this. Might be a good idea for folks who've had questions about whether they have conflicts to think about if you need to reach out to the Ethics Commission for any clarification. And with that, I'll turn it over to, I think since Adria is not here, are we just starting off with Tammy?
Yes.
Good morning, everyone. We do have just a few updates this month to be able to report. If you can go to the first slide for me with the numbers. We did not have any additional revenue coming in, any payments that were added into our existing allocations and payments received table. But we did make some adjustments based on Annalise's feedback about segregating the AY25 emerging issues, which is the funds that were still available after the end of the last biennium, from the AY27 unallocated funds, the funds that, based upon the projected revenue and payments that are going to be received in this biennium, the available allocations, monies available for the board for your decision making. So in that AY27 unallocated funds, just acknowledging that we've already taken out the administrative percentage, the tribal allocation that the board previously approved for all payments and revenue going forward. And in addition to that, we had on July 1st the harm reduction allocation that the board had voted on actually in AY25 that was coming out of AY27 funds. That is represented in the table here, that 5,149,231 on July 1st on the allocations portion of this table. So just wanted to provide those updates. And then if we want to go to the next slide. I've also updated what the expensed amounts are for each of the allocations that we have with those updated totals. So for example, you'll see harm reduction has a higher total for an allocation because it does include that AY27 allocation. So I want to take a pause if there's any questions I can answer from the board. Okay, well, we're going to continue to track any additional expenses, of course, that are coming through, and then we are schedules and things like that for the additional settlements that are going to be coming in. We'll just wait for direction from Department of Justice on that, and when we get those, we will be updating all of these as well. So thank you, everyone.
Thank you, Tammy. I sure appreciate the work you do to keep track of all of this. So thank you. Okay, I'm just giving a couple very high level program updates. I wanted to give a shout out to Annalise and Adria. We just had our annual opioid and other drugs pain and addiction treatment conference in Sun River that we call OPAT. And we had a plenary session, which was a opioid settlement update. So Annalise gave the state overview. Adria gave an overview of what subdivisions have been spending their money on. And the real highlight was we welcomed Jacelyn from the Confederated Tribes of the Warm Springs and Jesse Spain from Painted Horse Recovery, who shared what they are doing with their opioid settlement funds. And the audience was so engaged, and there were so many questions that we actually had to stop, and we weren't able to accommodate everybody's questions. So to me, that's always a good sign that it was a great presentation. So I'd be happy to send you the link to that recording once it's posted on the website. And then, as you know, we have a monthly local opioid settlement learning collaborative that is run by Comagine Health, and the planning team includes ADPC, DOJ, OHA, and we have April Heron from Clackamas County, who very kindly provides the local perspective. And the October 2nd meeting was really to celebrate Substance Use Prevention Month. So we heard from the ADPC about their new prevention strategies. And then we heard from both Sherman and Umatilla County ADPEP programs. They are primary prevention grantees, as you know. And it was really cool hearing what their work is in reality in their environments. And it's very creative, and it was just great. And then our next meeting is tomorrow, and this is all about data. So tomorrow's meeting will focus on accessing data resources to make opioid settlement spending decisions. And so Annalise is going to share how this board used data to make your spending decisions. And then we'll have Liz McCarthy, an OHA epidemiologist, show local jurisdictions how to access their local overdose and SUD data. And then we'll be hearing from Clatsop, Tillamook, and Columbia counties about how they use data in their spending decision making. And then the Oregon Council for Behavioral Health preventionist trainings, it's really the Oregon Coalition of Prevention Professionals. They held their second certified prevention specialist cohort training, October 21st through the 23rd. And we have heard from several opioid settlement grantees that they have been able to come to these trainings, including a few focus grantees, such as Raven Lopez, who's going to be presenting later, as has been taking these trainings. So just wanted to share some good news, and I'll pause there for questions or comments. Okay, that's it for me. And this is Michelle.
Good morning, everyone. Dana is not available this month, but we wanted to provide a quick snapshot of the opioid treatment progress. We now have 3 fully executed agreements in place: Redmond, The Dalles, and Klamath Falls. Additionally, OHA's Behavioral Health Investments Team, or the BHIT team, has confirmed that capital agreement for Gresham location is also fully executed. Any questions related to the OTP expansion, please hold them for Dana for next month. And that's it.
And now we'll hear from Alexis about the quality improvement assessment.
Hi, everyone. So we presented, I believe last year, just a little bit about the quality improvement survey. And so we made some changes to that survey. And just to remind folks on the board, so the purpose of this survey is really to assess OHA's support of the board, also highlight the strengths that you all have, and then also promote equity through transparency by documenting different board processes and decision making. The survey asks kind of a number of questions. So one, we asked some questions about just the board composition under HB 4098, the board's responsibilities under HB 4098, we asked some questions about the board's meeting structure and procedures, implementation of funding, a couple questions in there just about the subcommittees and kind of how OHA can continue to support the subcommittees for folks on those. And then we do ask some questions about major accomplishments that the board has achieved so far and any areas of improvement for OHA about how the board might be better supported. The survey should take about 20 minutes. It's relatively short, 20 minutes kind of maximum. And then all board members will receive a survey link to complete this after this meeting. So like right after the meeting's over, you should see an email in your inbox from me. So it will be from my email address there. It's acook@comagine.org. And then we'll have this survey open for like about a month, and we'll send some reminders in case you aren't able to complete it today. But yeah, just please keep a lookout for that email and for that link. And if you could complete the survey, that'd be great.
Thanks, Alexis. Does anyone have any questions? Great. If folks could fill that out, that'd be helpful. Zach, I think, is going to give us an update on the research evaluation and data subcommittee.
Yes, thank you, Annalise. Just a quick update on what the RED subcommittee is working on. At our last meeting, which was on October 15th, the group reviewed OHA controlled substance prescribing data as part of the effort to advance the data system framework that we shared with you all a few months ago, again, focused on MOUD data at this point. So we continue to work through that process, and there's a lot of behind the scenes work going on to identify the appropriate data sources and tools that we can use to advance understanding of that topic. We also had some presentations on evaluation from Comagine, who presented an all-payer, all-claims baseline analysis that's helpful in understanding the general situation regarding treatment. And then we heard from the ADPC, Mitch Doig presented on a HB 4002 update, and that requires the ADPC to conduct a study of barriers and best practices for access to OUD treatment and MOUD for youth and through emergency departments. So that was really helpful context setting for the research and evaluation and data subcommittee as they make their decisions. We'll continue to work through both the data part of the portfolio and the evaluation part of the portfolio. And hopefully we'll be before the full board early next year with some recommendations on next steps moving forward. So that is the red update. Are there any questions on that? All right, thank you.
Thanks, Zach. And if anyone wants to join that committee, I think those of us who are board members who are on that committee sometimes have a little bit of trouble fitting it into our schedules. Sorry, Zach, I know I'm going to miss the next meeting too. So if other members would like to join, please let us know. And with that, we get to move on to the fun part of the meeting. We're going to start with the primary prevention presentations, and I think I'm handing it over to Lisa to kick it off.
Okay, I just wanted to introduce you to my wonderful colleague Mackenzie, who has has really emerged as the lead for the focus grants, and he'll be giving you an overview of what these focus grants look like. But I do want to share that he is funded by the CDC Foundation to provide support to the Overdose Data to Action grant. And one of our initiatives in public health is making sure that these federal grants align with the work we do to support opioid settlement work. And so this primary prevention grant work is part of a larger body of work that we support. So Mackenzie has been amazing, and I'm so grateful to have him. So take it away, Mackenzie.
Awesome, Lisa. I'm glad you mentioned that part and I didn't have to. Hi, everybody. My name is Mackenzie Bullard. I am an overdose prevention program coordinator here at OHA and the Focus project lead, he, him, él pronouns. And I'm really excited to be here today to talk to you all about the wonderful project that you funded, which was the Promoting Healthy Outcomes with Culturally Unique Solutions, or more commonly known on our team as Focus. Next slide, please. Okay. Awesome. So today I'm going to talk to you all a little bit about the Focus overview, remind you about what it is that we were doing with this, some of the project highlights, and then I really want to talk to you about our approach to how we do this stuff administratively and how we support our grantees as they've moved through the project. Okay, next slide. So these are the focus goals. Here at OHA, we follow the data, right? And you all do as well. And that's why the focus grant was put out to priority populations with the highest disparities of overdose death rates here in Oregon, and those being the Black African American community, the American Indian and Alaskan Native communities, and people who do not speak English as their primary language. All of our grantees run that gamut of those priority populations and serve those communities, not just because they're organizations that work with them, but are embedded in those communities as a part of them. And so just to say that these are made to build community-based strategies, partnerships, and programming to reduce and prevent initiation of substance use and substance use disorder in communities disproportionately impacted by harms related to opioids and other drugs. Next slide, please. So here's the funding overview. The RFA went out to organizations, I believe, that did have existing OHA contracts. So these are folks that were familiar with our process, applications, and things that they needed to do. That helped us streamline and get out the RFA in a timely manner. I wasn't so much involved in that part of the things, but that's important for you all to know. We ended up funding 13 culturally specific CBOs, one of them who is with us today, Los Juntos, and I'm really excited for Raven to talk in a little bit. Those projects were funded around $200,000 per project. those projects started at the beginning of this year. It's kind of crazy, right, Raven, that like it's already been a year that we've been doing this work. And they can run until the June 30th of 2027. But some folks are winding down their projects and have already implemented all their activities. So they could have ended earlier than the allotted time. Next slide, please. And here are the grantees. I think it's important, I lead this work with the community engagement mindset always. I've been doing this work for about 10 years in substance use prevention and community engagement, all the way from being in the Peace Corps and doing alcohol prevention with folks in Guatemala and Peru to Millennia Cast in Boston, Massachusetts, and harm reduction work. So this group of grantees is unique, special in so many different ways, and is doing the work at a very high impact in a very high impact way. So I'm really proud of them, and I wanted to give a shout out to all of them today on this call, even though not all of them will be talking with you all. So these are their logos and their names. Thank you to all of our focus grantees for helping save lives. Next slide. These are where the applications came from, but these are the counties I believe that are represented or served by the focus grant. So you see that there are folks not just from the Tri-County area, but all over in some of the rural areas of Oregon. And yeah, that's that slide. Let's go to the next one. These are some of the highlights of the activities. A lot of them are really about community education and doing a lot of programming to do prevention work, whether that be through sports, sweats, community, basket weaving, drums, all kinds of different things that folks are doing in their projects, but always with a hint of making it known that, there are other ways to deal with stress, trauma, and things that are going on with your life, and to get you connected to things that don't have to involve substance use initiation. And so these are just some highlights of those. They're not specific, but they're general because a lot of the programs kind of fall into some of these buckets. So yeah, I'll let you read these for a second. And I can speak about any more specifics if folks have any other questions about these things. But I think the one that's really important to me is, and a lot of them in our one-on-ones always talk about, is like we're just building trust, and making people feel connected to the things that can help them and their families find other ways to deal with all the things that are going on in life. So instead of drugs and substances. Okay, so let's go. Let's keep moving. Sorry, I see the time. Let's go. And this is the important thing for the board to know from the OHA side of things. Internally, we lead with a community engagement mindset. I did not mention at the beginning, but shout out to Tammy Kelly, Lisa, and Robin Hermstead, who make this project happen in the background. They make it all clear for us on all the things we need to do for low barrier possible lift for our grantees. So my work with the grantees, I do a lot of things to help them feel supported. And one of the things that they say to us often is that they feel like they're part of a family or a network of grantees. They're not just folks that are getting money to do work, but they've become a part of the overall overdose prevention network that we're trying to build here at OHA. And that includes one-on-one quarterly meetings, quarterly group meetings. They love that. And Raven actually gave a suggestion to make sure they do slides next time about their one slide share out. And then monthly office hours where we just kind of hang out and take care of things. And then there's a one-off TA request for getting people connected to any and all kind of resources we can on our team. Now I'm going to pass it off to Raven Lopez, who I just got to say is an outstanding grantee. Her work with Todos Juntos is something really inspiring, and I think you all are really going to enjoy the work that they're doing on this focus grant. So, Raven, take it away.
Thank you, Mackenzie. What an introduction. Just want to shout out, I'm a little nervous. I've never presented in front of a board, so I excuse my cracky voice. And I had the pleasure of being at OPAT. I did not get a chance to connect with Lisa. She was busy, but I did see you, Annalise. And I mean, I just, as a prevention person coming, I was really happy that I attended and felt like learning just overall, we need to know everything as substance, and so knowing, how is treatment happening because I'm on this realm of it. So it's just really it's a spectrum and we should all know about each other's work. And I love that we really emphasize that at OPAT of like we're in this together. Like we all want the same goal, right? Is to save people's lives and to prevent more, people being impacted. So um a little bit about my organization. So I'm with Todos Juntos, which means all together. We are a nonprofit in Clackamas County. So we serve rural Clackamas County for those of you that are aware. So we're out here in Sandy, Estacada, Malala, and Canby, and then like those surrounding rural areas. So Colton, Malino. I mean, there's just all these little pockets of Clackamas County that um, gets forgotten quite a bit. So our mission as an organization is to create connections that empower, educate, and inspire children, youth, and families. At Todos Juntos, we provide services by offering like in-school and after-school programs. We have parent education. We do early childhood and like play groups. We do family resource connections. We do brain boxes. We really promote and encourage, overall family stability and all of that. So I'm just one little ant in the army, right? So it's like what I do is, we all kind of wrap around families. So it's a beautiful organization and we got a good amount of bilingual staff, so we really work together and make sure we're trying to do things really equitable and inclusive. And so I just really, we just celebrated 25 years, so that was a big one for us. So yeah, we got our boots on the ground and we're working hard. So that's a little bit about Todos Juntos. And this was at our last little 25-year celebration. We just had a little thing in October. So. Oh, next slide. I forgot I'm not controlling. So just a little bit about me, you guys. I think this is important, and I also love that this was touched on at OPAT of someone being. I'm not a peer, but I have lived experience. Like I'm the kid that we're trying to reach, right? Like so I grew up with a lot of lived experience with parental addiction. My dad passed away of an overdose. I had family impacted by suicide. I had a family member complete suicide at a young age. My husband's actually in recovery from opiates. He's somebody that was really early on in those opiate prescribing days, and it flew into a full-on addiction. He'll celebrate 12 years sober next month, so that's huge. So two of our kids don't even know that side of their dad, right? So it's just really a beautiful thing. I was a teen parent, so my son just graduated high school. So like that first generation cycle breaker, right? I'm like a high school graduate. My son just graduated. So now I have a second generation. I graduated college, bought a house, did these things, right? And so I really don't mean to say this to try to brag, but I emphasize to the kids I work with, like you get to make the choice of what your destination is. And so I really love the little quote there. It's kind of small, but it's basically saying like we're not, we're all dealt that deck of cards, but like we're in charge of how we shuffle and use them. And so like really inspiring kids, like just because you live that and you see like this is your family kind of lifestyle, like we do get to make choices that change that. And so, that's what is important to instill with kids that come from kind of this lifestyle and background is like I can't save you, but like you can change what your choices are. So that's kind of the big one, my takeaway here. Next slide. So just kind of really touching on the topics for this grant, I just wanted to do a little bit of a heavy slide here, but really make sure that I'm kind of emphasizing to y'all like what this grant meant for us. Again, I'm specifically in Malala, so very rural area. We don't have any treatment facilities here. We don't have, I mean, we have to, everybody's got to commute out if they want to get behavioral health or SED support or any of those kind of things, right? So we're already rural. We aren't on like a normal TriMet line. You're not, we don't just hop on a bus. We do have like one bus that will come every now and then and take you to CCC, and then you got to get on like the, so it's just to give you a background. Like it's pretty rural out here. So a lot of families, that's a big barrier. Um, just jumping into like a challenge, I kind of started at the bottom. So, just the lack of this is what we're facing. Like we have a lack of resources overall, just being rural. And then if you add like what we're lacking for behavioral supports, for SUD supports for students, we're just lacking it. And then we don't have transportation. And then we're then we talk about having SUD or behavioral supports bilingual. Wow, where are we finding them? So it's really just it's a really barrier out here, and we support the schools and support bringing the community and county out to us and trying to alleviate some of those barriers. And another challenge that we face, and everybody kind of faces, which was kind of nice at OPAT. Parents aren't really eager to come learn about prevention and engage and stuff, right? So we had some low parental engagement. I tried to host some workshops and stuff, and we even teamed up with the school and tried to do a vaping presentation. We just had really low numbers. And so what I started doing was shifting that. I'm going to go to where the parents are already going to be. So back to school night, basketball games, when they do conferences. If I have a table with like a staff out there, usually they'll come over and start talking to me, and then you kind of get that dialect going. So I kind of shared that wisdom with folks, is kind of meet them where they're at to try to spread prevention and start talking about it more, so that we're not getting bummed out when we have no one showing up to things. And then, so like, let's get to the good stuff. So I mean, this really allowed me to continue doing what I'm doing because I was going to lose my funding. So I was able to secure this grant and therefore never had a lapse, and was able to just like continue pushing into this, into the prevention funding. And prior to that, I think my grant was only 18 months. And so kind of like Mackenzie said, I had just kind of gotten at the door. The principal was like, okay, what are you, like you really have to build the rapport with them. And so had that gone away, like we would have just lost all of that. And so thankfully I was given funding to continue this. And in doing so, I have increased our school engagement, increased our partnerships, like with working with the principal and all the people that are the key players. And bringing prevention, we did prevention month this year. We didn't just do Red Ribbon Week. We're engaging, and so it's increasing my ability to do that, to offer culturally specific group. This is the first year Malala Middle School has let us do a Spanish speaking circle group. We had to fight, like I don't mean to say it like that, but it was a it was a challenging conversation. Like, how do we pitch it? And I go, well, I'm not really understanding. They either identify with this group, they want to go to a cultural specific group, or they go to a not. And I'm like, so we're not disqualifying anyone. It's like, who do you identify with? And so we have a Spanish speaking instructor like leading. So we've just made really, really huge successes. And then as soon as the school sees this, they're like buying in, and they want more, and they want to continue this. And so I'm really excited for what this can look like to continue to build on. And then the partnerships with not only the middle school, but branching into the elementary. So those transition students, fifth graders coming in, and then our eighth graders going into high school. So helping with those warm handoffs, transition, supporting students that we know really need additional, kind of like wraparound support. Next slide. I know I'm taking my time here. So again, just really emphasizing like the big prevention is I'm boots in the school. I'm doing girl circle groups. So like this is a picture of one of my girls groups. We do a really fun, last one we did it was holiday themed. But so these girls meet with us. We meet, 8 weeks at a time, one time a week, and we talk about resiliency and friendships and goal setting and like refusal skills. I mean, it's all very, important stuff. And so I do that. We have a male doing male focused boys groups. And then we have a cultural specific group if they choose to go that route. We do Healthy Futures, which is a Stanford Harmony vaping curriculum. If anybody's familiar with that, it's free. It's amazing. It's a great way to just meet with students who are kind of needing a little more of like their prevention, but kind of leaning into intervention because they might have been caught with somebody using or something like that. So really supporting the school with what they need. They need SUD and they need supports like that. And so I'm like, here's what I can do as a non A&D counselor, right? So like I'm stepping in where I can and where I can be competent in my career. And then just a picture of something I put together there. That's my clothing corner, free corner. Kids are able to take backpacks, hygiene supplies. People donate coats. They come in, they grab stuff from my corner. So just really helping with resources. Okay, next slide. Another huge one, protective factors, after school clubs. We have nothing. We don't have YMCA. We don't have, I can't even think of things. I mean, we just don't have a lot going on here. So like that gap hours, we all know kids. So we get out of school here at 2:17. How many of us are home by that time? Not working parents, right? So like that gap hour of like 2:30 to like 4:30 is super crucial. So we do a lot of after school clubs. We're doing a lot of STEM based, robotics, creative design using our Cricut machine. We do the soccer club was huge. You'll see my picture down there. We had somebody sponsor our t-shirts. We went and took them over to Canby and played against the Canby team and we won. Just got to shoot that out there. But so they were so excited because they won the game. And for some of these kids, this was their very first time being on a team sport, like very first time. So about half of these guys were going into high school. We made sure we connected with the high school coach, brought him over to watch them and got them connected so that I can say with like I'm just beaming. 6 of them are playing high school soccer right now, or the season ended, but one of them made varsity his freshman year, one of the kids. And so just these kind of supports, I'm making sure that I'm keeping protective factors going and kind of like keeping them. I'm not just like, getting rid of them once they go to high school. I want to make sure they have a warm handoff. Okay, so, and then last slide. I believe, oh, sorry, next one. I have 2 more. So this, and then, so not just doing after school, we do during the summer, we're doing it during spring break. So I'm really trying to bring what I can. I'm a mom in the community. I have kids myself, so it's like I know they need this. So a lot of outdoor you'll see here. We're doing flag football. We got basketball going on. We got soccer over there. The dog right there, that's a what's that called? Like a companion type dog or whatever. I'm sorry, I'm blanking, but she brings it in and he's like an emotional support dog. So the kids just like love that. And then on my last slide, I apologize. I'm going a little fast because I don't want to. Oh my goodness, I have more. So this is more community events. I do parenting classes, you guys. So I really just wrap around like what I'm saying to my parents. I'm also saying like, hey, this is prevention. We need to talk to our kids about this earlier, the better. So it's really, I'm trying to throw prevention anywhere I can. And then laser tag, for example, we had a really fun laser tag event, but if you see on there, I made it a family event, team up against making smarter choices. So I had lock boxes and it was like a safety event, but then the kids and the parents came because they wanted to play laser tag. But then they started talking to me and ended up leaving with lock boxes for their guns and stuff. So really a win. And now finally, the last slide. I forgot how long I made this. So this is my, I'll be quickly here. This is my kind of really excited moment. We just finished this up. So this year we were able to just really push Prevention Month and Red Ribbon Week at the middle school, and they sent me 4 kids from leadership to support this, and they worked with me all month long, and we came up with that contest. So we had like a logo coloring contest. We came up with the days of the week over there, and we made sure we translated everything was bilingual. I should kind of specify that everything I do is always bilingual, is always sent out bilingual. Um, and we supported students making bilingual. So you'll see he did it in fully Spanish, making bilingual posters and making sure we're representing all the students' voices. And we just really had a great prevention month, and I'm just excited to do this next year and make it even bigger. And so that's kind of where I'll end. I'm right at 15 minutes if I timed myself. Thanks, guys.
Thank you so much, Raven. You did fantastic. So much energy. This was absolutely amazing. Do folks have questions? We've got a few minutes.
We should have at least 10 minutes for questions. So yes, bring on the questions.
Zeb?
Hi, sorry I missed the first part with Mackenzie, but I caught Raven. And I just want to say thank you so much to you both. And Raven, out, you may have been nervous, but that was an amazing presentation.
Oh, thank
It
you.
was
I
a- it
did
was
feel
a-
really nervous.
No, it was amazing. And the work that you're doing and the impact you're having is just amazing. So thank you so much for what you do. Just want to
Thank
say that.
you. And I should have said this, I guess what is the biggest issue though is I got to keep doing it, right? So funding, and that's the problem. And I kind of stressed this to Mackenzie even at OPAT. And sorry to keep going a little bit, but just to stress to you all, I have the beauty of working in one community. Yes, it's a broad community and we're big and this and that, but I was meeting prevention folks that were supposed to be doing what I'm doing in like a whole county. And I'm like, you have to be able to like be I have to have the community buy-in. It takes so much time just in one community. I can't imagine trying to stretch myself so thinly. And I just wanted to plug that out there. And so it's like it's quality over quantity sometimes. Like we need people to like take, and really emphasize and I hope I can stress that. Like if this all goes away, then it all goes away again, and then we're back to square one. So it's kind of like a uphill battle, right?
And can you just say real quick about that, Raven? Like, what was your funding before? Like, it's so hard in this space that there's no sustainable funding. Like, what are your other funding streams?
Gosh, and you know what? I don't have my last one pulled up. It was a federal one that did get cut. I know that it took a cut when this all happened. The other we are big OPEC, so we all do parenting classes in all of our communities, right? So we're bringing in OPEC, and we have a lot of early childhood. There's a big early childhood funding, which I think is great. And now we know prevention is really family focused. Like that's what my big takeaway from OPAT was like, yeah, by middle school, I'm already kind of behind the scenes. Like I need to start like earlier with parents, right? So we have a lot of STEM grants that we got, all these random kind of ones, but not a lot of prevention grants in Todos Juntos ourselves, if I can answer, like one of three that can do prevention work in our whole organization that is solely funded for that.
Thank you.
Yeah.
Lori?
Thank you. Thanks for a great presentation and your obvious commitment, enthusiasm for the work. It's phenomenal.
Thank you.
And similar, my question was sort of similar to what Annalise asked, but I'll ask it sort of anyway. About other funding sources. And you're so right. Your work going in partnership with the schools and now with early childhood ed. Sometimes they have programs that aren't named prevention programs, but the work they're doing is prevention work. So where those opportunities are to find those logical like pairings and allies to leverage funding they're already receiving and do a little match or a little value add. It just feels like this is a kind of program that is absolutely ripe for that. And similar to your experience with the soccer team, you get private companies to sponsor a team. They can also sponsor a program or sponsor materials. Or it just seems like you're on such the right path to find those allied partner entities. And again, just to expand your opportunities, because that was going to be my question: is where else is your funding coming from, and where do you see opportunity? Because it's the available resources are getting smaller while the need continues to grow. So I just see you setting yourself up for getting noticed by and having other kinds of groups feel like they want to be part of what you're doing, even if what they do isn't named prevention work. So good
Yeah.
job.
Thank you. And I hope that is the takeaway too, because like I'm part of the cohort for the, like she said, before I've done doing this 9 years, I never really worried about getting that certificate. And now it's a big deal though. Like we have a bill that says what prevention is. And so I'm part of that first cohort of the OCPP prevention, and so it's exciting work. And I think the more that we all talk about what it is, and prevention's everywhere, it really is, like you said. And so um, changing our lens on it's not just me doing after school clubs for middle schoolers, right? It's like really getting in there and kind of updating our family systems a little
Exactly.
more.
Yeah.
Is
And
kind of,
working with the county programs that are there. I mean, the WIC program is a great opportunity, for example. They have, maybe somebody new coming into the program who's new to the community and newly pregnant, but has a kiddo who's as old as 5 years old.
Mhm.
That could be another good linking entity, and that starts getting you more embedded with your county public health
Yeah,
department.
totally. I could see that.
Any other questions for Raven? Fantastic. And I will just give a quick update for folks who don't know the bill that Raven was referring to, House Bill 3321 from the 2025 session defines primary prevention, but also the ADPC is going to be doing an assessment of all these types of primary prevention programs because I think as this conversation illustrates, we know that they're out there. Raven, you're so right. Like the funding comes from all different places, and there's a sense they're there, but they're not always funded by the state. And so getting us a good map of the assessment and where the funding comes from so that we can start to make you a part of our system. It's really exciting. So Raven, thank you so much. Mackenzie, thank you. Thank you both so much. I think we're gonna turn to treatment. Michelle is gonna give us some background and then Dr. Hoover will join us to update us on his work with MOUD technical assistance to jails.
Hi there. I'm actually going to give the background because I ended up being the contract administrator for this because it was before we had Michelle. So it was pre-Michelle times when things were much more difficult. So I'll just give a really quick overview. So just to refresh your memory, the board granted $250,000 to OHSU Addiction Medicine to provide technical assistance to jails for MOUD programs. And this has been such an amazing project to follow because Dr. Hoover hit the ground running. He was ready to go the minute the contract came through. He will be sharing with you more information about how he's building on an existing body of work across the state. But the details about this contract are that OHSU Addiction Medicine provides technical assistance to jails, up to 4 high needs jails in year one. And the definition of a high needs jail is a jail starting a brand new MOUD program and up to 3 high needs jails in year two. However, the reality is that he and his team have been involved with a lot more jails and other carceral settings than the requirement for the agreement. And then what this technical assistance includes is they have at least monthly meetings with these jails that are interested to develop programs. They have produced program materials that Dan will be telling you more about, including a clinical guide to extended release buprenorphine. They provide a ton of quality improvement support for each jail, and then lots of clinical advising to the jail-based providers, and that can be through meetings or the OHSU Addiction Consult line. And he'll be telling you more about that. And then the support that OHA provides. Look, this was a program that was shelf ready, ready to go. So we do our best to kind of stay out of the way, make sure they get the money and make sure they get the support that they need. But there's the usual contract administration stuff and processing of the money. But Dr. Hoover saw a need to bring together other programs that are working to establish or continue programs that provide MOUD in carceral settings. And so one thing, OHA has been able to provide is a work group that meets monthly that talks about challenges and successes in this setting. And there have been some really great connections made within that group. And so that group has representation from the ADPC, obviously, OHA, but several groups across OHA, including the reentry healthcare team and Medicaid waiver team and Criminal Justice Commission, Department of Corrections. It's just a huge work group that is probably my favorite work group that we have because it's so collegial and so informative. I learn something every time. And then of course, we're providing evaluation or program monitoring support. So just wanted to give a shout out before Dan goes that this work has been really eye-opening and incredible and making an immediate impact. So Dan, I'll hand it over to you.
Thanks, Lisa. That was a really kind intro, and it's absolutely been a pleasure to work with you on this. So, hello to everyone. I'm Dr. Dan Hoover, presenting to you about this update of the jail MOUD technical assistance work that we're doing. Is there a potential that I can drive my own slides just because I love to do that? And I added like one slide. All right.
Absolutely, you should have permissions.
All right, this will go easy to switch over, I think. Except I went to the end. Okay, here we go. I did want to say about my own background that this is kind of like a dream intersection of a lot of the work that I've been doing and I'm doing currently. So I do practice addiction medicine in a hospital setting at Hillsborough Med Center, which is in Washington County, currently. And then the way I got interested in jail work was through a research partnership and grant that Clackamas County Jail had, and I started on that in 2021. Really tremendous, I think, how the research advanced the science and also the local implementation. And then through the state opioid response grant, I'm the addiction medicine echo program director, and we do statewide education on Zoom, including a sudden jails echo that we launched in 2022. And that was not adequate to support jails. We needed to go deeper and provide more support, basically, as a theme here. I started doing regional technical assistance in partnership with the Eastern Oregon CCO in 2023, specifically for those jails because they're all high needs jails out there, is what we really recognize. They need a lot of support to develop these programs. And then there's some intersections also with my work for the Criminal Justice Commission, where I direct the deflection implementation, technical assistance, and of course that's upstream of jail. We're trying to avoid folks going to jail. And then I'm also on the jail MOUD grant review committee that is funding a lot of the jail programs that are being built and developed. So in my update here, this is the outline for what I'll cover, the origins of the grant, the clients basically that we work with, and our team. I'll give you some examples of the technical assistance TA that we're doing, talk about the infrastructure that's more behind the scenes or kind of state level, and then some of the future work we'd like to do. So I guess this is kind of repetition. We do learn by repetition. So this is what Elisa covered, that we're funded by the board. We're actually funded in the same meeting or decisions as the OTP expansion, a lot of satellite OTP sites, and then launched our technical assistance in October 2024. That was really at the same time as the first cycle of jail MOUD grants applications going into CJC. And that was intentional to get the TA up and running along with the grant funding to jails. And as Lisa said, this was our scope of work to serve the jails. And we are going beyond that, excited to say that we're going beyond that, and there's a lot of needs. What about the clients of the TA and our team? So for the statewide TA, in the year one, the high needs sites that we worked with are Norcor Jail, their regional jail in Hood River, also Crook County Jail, Benton County Jail, Multnomah County, MCDC, and Inverness, the two jail sites, and then the Oregon Youth Authority, which is not a jail, just to be clear, but excited that we talked to Lisa and concluded this was a good use of our resources. We also did a couple of one-time consultations with jail teams. And then this is our OHSU team. Dr. Weiner was in a lead provider role for the TA and has really incredible withdrawal management experience. And he's moved to New York. So now Dr. West is our lead TA provider. And then we also have pharmacists supporting us, the medical director at OHSU's Harbor Clinic. He's specifically leading the technical assistance for Oregon Youth Authority. And we've got a skilled coordinator helping keep track of it all. I did want to mention the Eastern Oregon work is still going on, and my effort on that and a small team is funded by the Eastern Oregon CCO specifically because we're still doing a lot of effort to support these jails. Union County is officially graduated from our technical assistance, but these others we're still working with them actively. And Lake County is a brand new applicant to the jail MOUD grant, and we're just starting talking about how to lay the groundwork now with them. So Eastern Oregon CCO has been amazing and says they're still committed to this. They used to actually fund the jail programs originally back in 2023, and now the jails get the funds from the CJC grant. I want to give it some color, sort of about what we're actually doing on the TA calls with jails. So I picked two examples here. The first being Crook County, and in Crook County, Best Care is the specialist essentially who's providing MOUD services, and they're providing that in the community, of course, as well. But they had a desire to open this program at the jail, and then we meet every month with them and the jail health team and the jail commander and peer support specialists also who are at Best Care, and the jail health team's in like a screening and referral position towards the Best Care program. When they came to us, they did not have a program in the jail and wanted to launch a program centered around the injectable buprenorphine extended release. So we helped them set up the systems for that, and they also are currently working on getting a peer to come in the jail and establishing the workflow for that for more release support. They launched in wintertime, and then when I got numbers from them back in August, they'd given 25 injections to folks through this program already, and they're also in the naloxone clearinghouse program. We help them get set up with an account so they can distribute naloxone. And this is a photo from Dr. Weiner going out to do a training for them. Second example here is Oregon Youth Authority. So they have youth in custody for longer sentences, obviously not a jail, and they're statewide, which poses some interesting challenges in terms of how to provide the services they need. We help to match them to OHSU's telehealth low barrier buprenorphine clinic called the Harbor Clinic, and they have a statewide ability to engage and serve clients through telehealth. And they also, the medical director is family medicine, and they will serve youth very importantly because a lot of specialty MOUD prescribers will not see youth. And the OIA substance use disorder team does the screenings and referrals and then sends the patients to Harbor for the prescriptions. Their goal was to, for the first time, have a program where they could have youth in the facilities on sublingual buprenorphine, and that they could do it across their system and make sure that high risk youth with opioid use disorder or potential for overdose, that they could leave the facility definitely on medication if that was what would support them. So that's what we've been working to build, and we're now operational, having seen the first patient, I'm excited to say, and starting with Oak Creek facility for them. So the future work is expanding to more of their sites, replicating the workflow. Then I wanted to spotlight some of the infrastructure work that's not really confined to a single facility. And some of the things we did early is we made this extended release buprenorphine guide. We also produced a coordinator's contact list so that state agencies and individual jail programs know who to call regarding MOUD at a certain jail. We work with those MOUD grantees and help the CJC to understand what's going on with each grantee. The clearinghouse I mentioned, because we've helped jails make connections to the clearinghouse and get set up for naloxone. They're not, we don't have 100% of jails enrolled in the clearinghouse program yet, and so still have some work to do on that. I want to kind of draw connections to grant funded programs that are already in existence. So the Harbor Clinic OIA partnership, the Harbor Clinic is in large part grant funded with their operations by the State Opioid Response Grant, which is SAMHSA funds that come through OHA. So feel good about us kind of connecting the use of grant dollars to good effects here. And then similarly, I have funding with our addiction medicine echo program for the jail echo, and there's connections we're drawing there. There's also funding inside of what we call jail diversion funds that goes to community mental health programs, and we're helping get the CADCs or peer support who are usually funded by that. We're helping plug them in so that they can support clients on MOUD at the jails. And Best Care is a good example of that work. Also, Union County. There's a lot of jails that are doing this to good success. We also know about those OTPs, which are expanding, more sites coming online, and I'm going to give kudos to Oregon Recovery and Treatment Centers because they have a new site in Hood River, Dalles area, and they were very proactive in talking to Norcor Jail, and so we applaud them for that because we want to help build those connections. I guess I don't know exactly what to call our group that Lisa. So Lisa said Dan helped to set this up. I say Lisa and Michelle set it up, but it's our carceral collaborative group that includes state agencies, co-imagine evaluators, DOC, and that's been tremendous and helps us respond to things and problem solve and think about the future of this work in Oregon and how to do it the most effectively. I do want to highlight methadone to the board for a moment, and because we have some special work focused around methadone. This was in response to Multnomah County and some of their requests as we're doing TA with them, that they wanted to hear what others are doing about methadone. It's very complex to implement methadone inside of a jail. And so we launched a learning collaborative, ECHO, to gather Oregon and Washington jails as well to share about how they're doing methadone. Washington is a little bit ahead of us in terms of methadone in their facilities. And this is also exciting because Multnomah County is invested in this basically with a 50-50 partnership of running this ECHO for us. One of the early topics we're addressing on the ECHO and that I will be sharing with the jail commanders about soon is this exception pathway, basically, where jails have a few ways they could build methadone infrastructure, but a lot of it is really involved from a regulatory standpoint or might be expensive to them. And there's actually a very easy way to do this where DEA and SAMHSA agreed that a jail can essentially pretend to be a hospital and get a certain DEA designation that allows them to order methadone in-house and give it to individuals. And they have to meet some criteria, but this is accessible to jails and is really like designed for jails to take advantage of this. So I'm hoping to get more uptake in Oregon jails. We have exactly 0 jails that are doing this in the state currently. But I think there's big potential. This is not to replace OTPs doing services to jails, if that's a question, because OTPs are providing a lot of care that I think would augment the ability to do this special pathway. And this is great for remote jails and rapid care that's needed or bridging care before you can get all the coordination with an OTP. We also have a pretty neat train the trainer opportunity where there's a consultant offering free services who is with John Hopkins, and she has like a nationwide mandate to get jails and prisons using this pathway. So we've been consulting with her, and she's offered to help our jails directly or train our team in how to do this pathway. I think I got one slide on the future. here, as I was just saying on methadone, I want to work on scaling this up for the jails. Um, I am also worried about the disengaged jails, as I put this. It's not totally being fair to them to say that they're disengaged, but there's different barriers that different jails face, and we're not seeing every jail is not applying for the CJC jail MOUD grants. So to me, I think we have some jails that are essentially disengaged and maybe not feeling they can take advantage of that grant or are poised to do that. A lot of them, I think, do need technical assistance just from when I talk to some of the non-adopters about this. Also, we've got facilities that are not really in our scope to reach, being the juvenile detention facilities. And then we also, I think, have some potential to draw in research evaluators. I've had a couple of meetings to talk with researchers about doing more around carceral connections to Medicaid, like after release, or looking at jail programs. So hopefully that for the future, that's not, I'm staying focused on directly helping jails build infrastructure, but I think there's interest where folks even from out of state want to look at these systems. And the last point here, I'm disappointed. We thought there would be a Medicaid waiver so that folks close to release or in a short-term model in jails could be on Medicaid, and that would help to bridge over a lot of care transition issues that we have around jails. And that's not going to be implemented. So I'm in like a concerned community, basically saying, how do we respond? How do we work on release transitions without what we expected coming and having Medicaid continuity? One idea here is that methadone is cheaper, actually, than what a lot of programs are doing. So I hope to use that to get their buy-in to some of the methadone work. But I do think on that carceral collaborative group, we'll be problem solving sort of what is the best directions to go in if we don't have the Medicaid waiver coming to help our jail facilities. And that's everything, and would love to take some Q&A.
Thank you so much, Dr. Hoover. Appreciate your passion in this area. Do folks have questions? Lori.
I can kick us off. Thank you. Thanks so much for the presentation. I'm a county commissioner in Lane County, and really appreciate the work you're doing. I share your sadness. I'll see your sadness and raise you a really mad about the 1115 waiver program. It's so hard, I will just say, for counties with the current funding picture and the current state formulas that allocate funds to counties. Lane County has the highest percentage of high acuity folks who are under supervision, and yet face reductions in our funding. So we are really working hard to put together, as you probably know, strong programs in the jail, strong mental health and addiction treatment programs for folks under supervision. And then we've also stood up what I think is one of the best deflection programs in the state. And yet we just keep having our resources chipped away at. So it makes it harder to just maintain what we have, let alone grow it or increase the connectivity. I'm really curious too, what your experience is over time with the various contracted providers that work inside jails, right? We contract with WellPath right now. You mentioned Best Care in some of the other jails. Are any of the jails you're working with still using their own county staff or internal resources to manage their jail medical and or MOUD programs, or is everybody contracting out? And are you noticing differences across the contracted entities?
Yeah, I really appreciate that question. It's a varied landscape, absolutely. I'm aware of some examples where I think the care is not as good using a large chain of national correctional healthcare when it comes to the MIUD services. So I have seen some examples of that. I also have an example at Umatilla Jail where we the community mental health provider, which is Community Counseling Solutions, CCS, they operate the program, but there's very, very strong support from MedTrust. That's the jail's contracted general health provider. And they support meaningfully by doing the screening and referrals to the MOUD program, and they assist with the dispensing process, and they're going to be assisting with delivering the injectable buprenorphine injections as well. So it's hard to say it's kind of only one thing in response to that. Just from the list of the statewide TA clients, I can say Norcor Jails implementing this in-house with their medical team. Crook County, I don't, Best Care is not like a correctional health contractor. They have like an in-house jail team and don't use a large correctional vendor. Best Care and the in-house team are partnered. For Benton County, it's the FQHC, it's the county community health centers that runs the jail medical program and the full MOUD program. Multnomah County, it's the county that has a county corrections health division that does all of this, general health and MOUD. And Oregon Youth Authority, it's they're like an Oregon Youth Authority is probably more complicated to go into, but that's kind of the brief outline, I guess.
Great. Thank you. If you are amenable to, I wonder if you might have suggestions. It'll be a little while before we go out for another RFP for our services, but perhaps there's some language in our RFP that we could be using now that these programs have a little more history to ensure we're getting the best providers specifically for these services.
Yeah, let me know if you want to connect on that in the future. Yeah.
Terrific. Great. Thank you so much. Yeah, I'll connect with our sheriff about it, and then I might get back in touch with you. Thank you so much. Appreciate the presentation.
Rick.
Yeah, just to add context for what we're doing in Crook County. So we're the community mental health program in Crook County, but we're also a large regional SED provider. And so we were really interested in setting up the jail program that the key metric is engagement and follow-up care once they leave jail, since leaving jail is a huge trigger for relapse into use. And so the collaboration with the jail is really around that context, and that fits everyone's goals, right? The jail, they want inmates that are easier to manage, but also that they don't have to see them again because they've escaped the constant rearrest cycle. So I think that's a way to go, but that you don't get if it's just focused on providing the service in the jail.
That's such a great point. I'll say we introduced some of the like peer support and release transitional planning. We actually brought folks from Union County who do jail diversion work, and they showed up on a meeting with the Crook County commander, and the commander was like, "We want exactly this. We want this in our jail." And then it was like, let's talk to Best Care about the peer staff and who can support it. And there's a forensic trained peer who's supporting it now. So I think they have like a great vision for that, and very supported by the commander too.
And if you can do this in Crook County, which is full-on cowboy culture, you can do this anywhere, okay?
I'll just ask a quick question. I'll segue from the cowboy culture. And Rick, you may be able to answer this too. And maybe this is something for us all to think about having CJC come in the future, because I think this is more a question about what we're seeing with the jail MOUD grants, but just thinking about outcomes and what we're tracking. I mean, we all know that there's an evidence base for intervening in jail to prevent overdoses. I've heard anecdotally from some of the jails that they're also seeing a decrease in disruptive behaviors. Rick or Dan, I don't know if either one of you can speak to that, or Sheriff Phillips, our new member, that would be awesome.
Yeah, good morning. Just to piggyback on some of the points already made, in Clatsop County, our Clatsop Behavioral Health Care, they do the prescribing and treatment for MAT in the jail, and we work really closely with them. It's great because we have peers, we got counselors actually doing, the treatment in the jail in addition to the medication. And then we're also doing a study with OHSU on using contingency management to keep people engaged in treatment once they're released. Most small jails around the state provide their own jail medical. It's pretty much only the larger jails that are able to contract with the companies like WellPath, and sometimes that's been difficult. Washington County's had a hard time where the contracted provider wasn't providing all the services in their contract, so there's a negative outcome, and then the county gets sued. So there's challenges using contractors for your jail medical. And then was there another question, but I forgot.
The outcomes that you're seeing from your program. I was just saying, I've anecdotally heard from some other places where the jail commander felt like there was a decrease in disruptive behavior.
That's a good point. So I was the jail commander back in 2016, and about 2017, I started bringing in peer mentors, and then we were seeing the withdrawal was getting really, really bad. And we started down the RMAT path under the guise of managing withdrawal, and it's easier and less liability for the jails. I mean, I knew where I wanted to get, but I wasn't the sheriff at the time. And so we started using it just to manage withdrawal, and then they'd come off of Suboxone while in custody. And then the next step was I got the sheriff to buy off on if someone's already engaged in treatment, we have a responsibility to continue their care while they're in custody. So then people were continuing their medication. And then 2020, when I became sheriff, then we started really trying to ramp up a full MAT program in the jail. It certainly does help with the withdrawal. Of course, Dr. Hoover could talk about fentanyl withdrawal and precipitation by using these drugs. It's complicated. It's not a silver bullet by any means, but it certainly there's less fights in the jail. It's better. It's better and more humane for everybody involved.
Yeah, thanks for sharing that. There's some jails I know also they expanded their MOED programs, and overdose in custody just stopped. Like they aren't having overdoses anymore because people are on medicine that need it, and that's a huge outcome too. A lot of the jails that I work with have really limited data infrastructure, and I can't ask them to like build that from scratch for me. I do have an example, like in Umatilla jail, the captain is keeping like a Excel sheet basically, and he says to me, "We're not seeing people as often as we'd expect to come back." So I'm like, "Oh, that's good." Seems like his opinion is it's changed the reincarceration rate, the exposure to the MOED program. And we've also heard jails say, "Hey, we're not sending people to the ER like we used to," which is good. So we hear about these outcomes.
I would just add one more thing. I think community-wide, the services we're providing in the jail and deflection, they all work together. We're building connections with people while they're in custody, and maybe they don't continue treatment. They lapse when they get released. But then when a peer comes around on the deflection side, there's already connections there. They're more open to re-engaging in treatment. It's not so strange. So I think all these things have to work together, and they do contribute to better outcomes collectively.
All right, John, last word, and then we're going to go to break.
Good timing. I was just going to point out, and I pointed this out when I moderated the OPAT corrections focus panel last week. I think in a time of either real scarcity or sometimes perceived scarcity, I think because there's a lot of differing information that comes from different angles right now in our world, you really don't have, and I don't think this is a bold statement, and I would say it's not just anecdotal, but experiential, and it's empirically based too. You don't really have programs that have this value for the investment in the entire SUD field, because just like Sheriff Phillips talking about the impact on behavior in the jail, the impact on future recidivism, the impact on overdose, which is the number one cause of death, people being released from incarceration after 90 days around the world, literally. You really can't have better investments for your dollars, or it's up there in terms of the value. So I just wanted to make that point.
I appreciate that. And I'll say we don't know what the future is of the jail MOUD grants after 2027. So that is on my mind. There's not a waiver to fund the care. And so we do need to think about it, but it sure is high value. I completely agree and the right thing to do.
Thank you so much, Dan. So I think we are just about at time then. So we're going to take a 10-minute break and then we'll come back to hear about recovery. Welcome back. As people are coming back in, I do want to note that we had several members join after roll call. Welcome to the meeting, everyone who joined late. Sheriff Phillips, you have already jumped right in as a member of the board, but I did want to give you a minute if you'd like to introduce yourself. As I'm sure folks know, Sheriff Phillips is replacing Lee Eby, so you have big shoes to fill, but we're really excited to have you on board.
Yeah, thank you. Yeah, Lee Eby is one of the smartest guys I know. When I became a jail commander, he was kind of like my mentor. Really, really knowledgeable guy. A little bit about me. Clatsop County Sheriff. I've been the sheriff since 2000 or 2020. I started my career here in 2021 or 2001. Graduate of Oregon State University and later Western Oregon University for my master's program. Met my wife Bree at Oregon State. We have two kids. A son Jack, who's 21. He's at Oregon State, and our daughter Jane is almost 17, and she's at Asbury High School. Kind of my philosophy in law enforcement is that our job is to just help people change behavior, right? And there's lots of ways to do that, and I won't get into like general versus specific deterrence type theory, but there's other things as well. So I think that the health of the community is really important. So I'm on the board of trustees for the Columbia Memorial Hospital, and then also I'm on the board for the community action team. That really helps people with some of those determinative health type issues, right? Childhood education and housing and food and stuff like that. So those are other ways I think I can support the communities and helping behaviors be good.
Thank you so much for sharing that. We hope you enjoy your time with us. I think it's fair to say this is a very, very thoughtful board that likes to make very data-driven, deliberate decisions. So hopefully this will be a great experience, and we're excited to have you.
Thanks.
And with that, I think I'm turning over to Michelle. We're going to hear about the work at Oxford House and True Colors. Michelle's going to give us a quick highlight of the recovery funding, and then we'll hear from Ed from Oxford House and Amanda from True Colors. I will disclose that my staff has gone to one of the new houses in Tillamook and done a piece from Oxford House, and I got to be at the opening of True Colors. So I, as co-chair of the board, have seen firsthand how absolutely amazing and effective in the community these recovery services are. So I'm really excited about this. So I'll turn it over to you, Michelle.
Thank you. Next slide, please. So today you'll hear from two recovery grantees funded through the Opioid Settlement Prevention Treatment Recovery Board, Oxford House, and True Colors Recovery. One of the ways that OHA supports these recovery community centers or grantees is through technical assistance, fiscal oversight, regular check-ins. Check-ins for the grantees that I'm working with is quarterly. To support like a successful program implementation. And a lot of times little things come up, they have questions, and we get to navigate those things together. Now, as far as True Colors goes, in partnership with the ADPC, the Alcohol, Drug, and Policy Commission, with OHA, they issued a request for information to identify recovery community centers who could provide recovery services and supports in counties with really great need, specifically Josephine and Klamath County. True Colors Recovery was selected and awarded $2.5 million for Josephine County. And they have got fiscal sponsorship with 4D Recovery and have established Rogue Recovery Center in Grants Pass, officially opening their doors in August. This is a 3-year project that began April 1st of this year and will expire March 31st of 2028. But 2025 in my notes. It's really fast. And then, so we get to hear from Oxford House, they were awarded $500,000 from the board
and followed by Oxford House is True Colors Recovery. I don't, Oxford House grant was implemented or executed before I got here. So I don't personally administer that one, but I know what great work Oxford does. So let's turn it over to Ed, and then we'll hear from True Colors after Oxford.
Great. Thank you, everybody. My name is Ed Smith. I'm the regional manager for Oxford House. I apologize if there's any delay. I am on vacation in a little rustic cabin that my family owns in Neatarts without internet. And so luckily there is a Oxford House in Tillamook that I'm sitting in the living room of using their internet. So yeah, next slide, please. All right, so just to tell you a little bit about Oxford House, for those of you that don't know, Oxford House was established in 1975. The way it was established was there was a group of men that lived in a county-funded halfway house with a 6-month time period. They come out of incarceration or off the street, get placed in the house. And anyway, they found out that the county lost the funding for the housing. And after, a moment of being upset, the men decided, why can't we do this ourselves? So those men started the first Oxford House in Silver Spring, Maryland in 1975. And kind of the way they worked is they wanted to, they'd seen a lot of the people come, in the 6 months or a few months that they were there, people returning back to the house. They found out quickly that 6 months was not enough. So they decided, why have a time limit, right? And so Oxford House came up with this idea that once we have more of a demand, there's no more corners in the house to put people, we'll open the next house and the next house and the next house. Oxford House is a nonprofit 501c3 that establishes, charters Oxford House and provides technical assistance to the nationwide network of houses. Excuse me. Each house has 3 core principles. One, that it's democratically ran, so it makes us a little different from other recovery houses, is that the men or the women in the house run the house. Everything from, the chores in the house, how the money is spent, things like that in the house. The houses need to be financially self-supporting. So what that means is that members, we are working houses, right? Either somebody is working, or if they're on disability or Social Security, something like that, then the house asks them to actually go out and be a part of the community somehow, doing community service some way. The other interesting piece, that every dime that goes into an Oxford House stays in that house. It does not go to Oxford House Incorporated. It does not. So the members have a democratic ability to decide, after all their bills are paid, what the remaining money goes for. They vote as a body on every dime that's spent in the house. The other thing that makes us a little bit different is that we do ask for immediate expulsion upon relapse. And I know that seems kind of harsh. The definition of immediate isn't what some of us may think. Sometimes it might be a day, sometimes it might be 2 days. One of the things that the staff does is build up, resources in the different communities and the areas, right? So we do everything we can to provide them with the information, with resources to be able to go out, go to a detox center, or go through treatment centers, or go to a different housing provider, so that they can stay safe and still re-enter into recovery. Next slide, please. All right. A few statistics. Nationwide, Oxford House has over 4,000 houses, 3,600 beds in 46 states. About Oregon, we have 240. Actually, I think I sent this a couple days ago. We're at 244 houses now, 2,035 beds. We're still in 24 counties and 43 cities.
One thing I can say is that the money that we received through this grant has allowed us to focus more on the rural areas so that we can bring what we offer to the much needed areas. Our occupancy percentage is 87%, so that just goes to show that we're not meeting the need in the communities. And that is a statewide number. If I took certain counties like Lane County or Umatilla, Union, Wasco counties, we're at 100% occupancy rates. Average applications per house per month is about 5, just under 5 applications. Average admissions per month is just under 1. The reason that is a lot of times, we have. I'm going to use Lane County as an example. We get about 40 applications per bed that is open in the county. And that's not to say necessarily that all 40 individuals show up for the interviews, right? Sometimes a few show up. These numbers too don't show that some of the houses will put somebody on a couch and let them stay in the house as a member until they find a permanent housing solution. So the demand does exceed the supply. Our average abstinent rate month over month is 94%. And it's funny because really as a team here, we think, well, what are we doing wrong? And we have to be constantly reminded that no, that number is actually a very, very good numbers. So we have high, lofty goals. Next slide, please. Okay, a little bit about the Oxford House opiate settlement. So Oxford House received $500,000 for a 1-year project. The proposed project was the expansion of the Oxford House model. Also established a reentry and training education initiative. With that, hire staff, an additional outreach worker, a reentry coordinator, and a training and education coordinator to the team. The team before this project started was a team of 6 serving 230 houses, I believe, at that time. So this brought us to a team of 9 with a much greater reach. Goals were to open 3 to 4 houses, establish 24 to 40 beds for recovering individuals, create information exchange and establish partnerships with community partners throughout the state, establish reentry initiatives serving a minimum of 50 reentering individuals, and establish a training and education initiative facilitating a minimum of 12 trainings serving 300 individuals. Next slide, please. So goals versus the outcomes. So we began in December 1st, 2024. It took a minute to find the additional find the staff, but we found the staff. So far we've been able to open 2 houses, creating 18 beds in the rural areas that were key to the project. Also, we have 2 more houses coming with 16 additional beds by the end of our project. Monthly, we've increased our monthly presentations with treatment centers, coalitions, jails, prisons, and shelters, establishing really, like I talked about before, that greater resource development for our members, for our community, getting the word of who we are and what we have to offer. Hey, we're in your community. And then specifically, with the reentry initiative, our goal was 50. As of the end of September, we had 108 reentering individuals that were served coming directly out of the prisons. And then the third goal, training and education. There were 4 monthly in-person peer-based trainings for Oxford House residents and staff on opioid overdose prevention, response, MAR pathways, education, and training. We served 1,107 members. As of the end of September, the goal was 300. Next slide, please. Some of the challenges that we faced and continue to face is real estate and rental housing costs. There just aren't enough for our model because we are a self-pay model. The members pay, what the members pay is how the bills are paid and how we survive. So we have to have these bigger houses, at least 4 or 5 bedrooms, and it's got to be a reasonable amount for, we want to keep our houses affordable for our members so that they can be there long term, they can achieve their goals, and work on things in their recovery that we put aside. Another challenge is transportation and employment for individuals in early recovery. Through resources and community partners, we're able to develop peer supported navigation from residents and outreach staff. So we're able to, build up resources so that people can get to their appointments, get to their jobs, build the infrastructure for them. And the other challenge is the time limited project award. And the solution really, what we can say is the houses that we've opened under this and will open before the project is over will still, will remain. But I would say, especially for the reentry initiative, that our fear is how to retain that going back to 6 staff members serving the entire state. Next slide. Okay, now I'm going to go specifically into what the positions did. So the reentry coordinator position helps to bridge gaps for adults in incarceration, returning to society in need of recovery housing with a focus, with individuals with OUD. Reentry in Oregon has helped to assist 108 individuals move. Oh, yes, I will move quickly. Move into houses since January 2025, and 45 of them were direct placements. That's just saying that what we found, 45 were direct. At the end, we built a system where we could work with the case managers and more sustainable. 75% of these individuals still reside in Oxford House. Next slide. Training education roles. Let's go ahead and go to the next slide. So, I'm sorry. Can we go back one slide? I apologize. So role of the training education coordinator, provide Oxford House members and staff and volunteers with knowledge and resources, to do trainings on overdose prevention and collect data, ensure up-to-date naloxone resources are present, and educate houses and individuals on MAP, MARN, and MOUD, educate MOUD providers on the Oxford House policies. Next slide. So just a little bit about what we did with the expansion and training outreach. We were able to focus on Klamath Falls with additional staff. We were able to stabilize the community, assuring long-term success of necessary housing with of 32 individuals in a community with limited resources. 2 new homes were opened in Jackson and Douglas counties with additional staff. We were also able to open a house in Wasco County. Community outreach to treatment centers, behavioral health, and our first house was open in Wasco County, working to find a second house. And actually, the news is that we are opening a second house before the end of this year. Next slide. So training a little bit more of the outcomes. There were 13 virtual naloxone trainings, 29 in-person trainings. 1,107 were trained of the members. We were able to collect survey data from 546 of them. Also, Oxford House of Oregon State Convention, MAP-MAR training every year. Next slide. I also want to go back to, not only does our training education coordinator train the houses, but we have that position has trained so many community partners up and down the I-5 corridor, reaching out for help. So I think respect of time, I'll go ahead and move on. Here's another slide. Maybe they will include them with you guys. Next slide. All right. Oxford House of Oregon. Today we have 244 houses across 24 counties, providing 2,035 beds. And just some of our numbers. We do accept children in all our houses. We have houses that are some men's houses that are specific for children, some women's houses that are specific with children, but children are allowed in all of our houses. And I think that is it for my slide. Any information, my information there, our website and our vacancy website. Thank you guys for the opportunity. We hope to be able to continue this work in finding another funding stream. I know going back down to 6 staff members after a year of having just 3 more is scary to us.
Thanks, Ed. We're going to go to Amanda, and then we'll open it up for questions for both of you.
Hello, everyone. My name is Amanda Ireland Esquivel. I am the Executive Director of True Colors Recovery. We are a nonprofit that started off in Portland, Oregon. We started off about 3 years ago providing recovery mentoring services and a community center, specifically in culturally specific services to the LGBTQ plus community. We were given the opportunity to go ahead and open up a recovery center and program down in Josephine County. And so we ended up developing a new program that was not culturally specific, but was able to go ahead and provide support to everyone in the county, as we identified that Josephine County was lacking non-clinical services. And we felt like the need of the community and the impact of the opioid pandemic was so extreme that we wanted everyone to go ahead and have a space to recover. Next slide. And so our new program, we received funding, like Michelle said, April 1st. And then within a short 5 months, we were able to go ahead and find a physical location. We were fully staffed. We were able to go ahead and start providing mentoring services a month and a half after receiving funding. And we've been open to the public since August 14th. We are right off of the main street in Grants Pass, and our program is called Rogue Recovery Center. We basically bring inclusive non-clinical services to rural Oregon, meaning that we provide services to all of Josephine County. So whether that's out in Merlin, you're out in Murphy, you're in Cave Junction, we're able to go ahead and provide services to anyone within the county limits. The main things that we go ahead and provide are peer support. We have the community center that is open 7 days a week from 2 to 10. We also go ahead and provide information about overdose prevention and Narcan distribution. And we are working towards education of the workforce in Southern Oregon, as well as community outreach to reduce bias and stigma that we experience from the overall community. Next slide. And why this work matters. And so, what we were able to identify was that Josephine County had one of the leading overdose rates in Oregon. I believe that we were number 2 or 3 per capita. And we know that there's these high overdose rates and also binge drinking rates within the county. There was limited services and lack of low barrier drop-in centers. And right now, Josephine County is kind of like a political hot pot of individuals that right now we're kind of caught up in this houselessness response where there's not a adequate shelter for the need out there. And the community has really mixed ideas surrounding what care should look like, where care should be. And so we're seeing a lot of individuals experience lack of stability when it comes to that. When we also wanted to go ahead and increase, support for individuals that maybe didn't have access to insurance, but still needed recovery support. And so what we're doing is we're addressing the and expanding rural outreach, creating sober spaces, and then also providing a connection and purpose for those peer-led programs. Next slide. So our implementation, we kind of took off running. So the minute that we received the okay that yes, you are being funded, we were able to go ahead and hire leadership from within. I had a mentor that was ready for the leadership role and willing to go ahead and move across the state to Josephine County. His parents lived in the Applegate Valley, and that's where he had come from. And so it really felt like a homecoming for him to come back and serve his community. And with the support of 4D2 being our fiscal sponsor, we didn't have to wait for funds to go ahead and hit our account, which allowed us to go ahead and be even more responsive. So we were able to go ahead and hire him, train him. About a month later, we were able to go ahead and do we were able to do interviews and then hire our mentors, which allowed us to go ahead and begin mentoring services by the mid-July. So we were able to provide mentoring services before we were able to open up our doors. During this time, we were able to locate a building, do construction, complete construction, and then our doors opened for our Recovery Community Center on August 14th. And so the information and data that I'm going to present to you is actually with about our first full, it's about 10 weeks of service implementation within our first quarter. Next page. So within that short 10 weeks, we were able to go ahead and do intakes for 39 individuals. And that is, it may sound not like a lot, but that's for 2 mentors. So it's quite a bit, and it's quite a lot for a short period of time. What we also found out is that we were serving a really large population of older adults seeking recovery or experiencing substance use disorder. And so what we found with this too was that we started to need to go ahead and change our approach to services, and we really looked into best practices for serving older adults that MACBO had published within like a DACM report. And so what we were able to identify is that we were serving individuals that had long-term substance use that ended up following into later on in age. We had individuals that had been in recovery for a while, but then started to experience some financial instability. And then that individuals that started to go ahead and develop their substance use later on in life due to grief, loss, and then also disruption of support from their personal recovery capital, maybe even a lack of employment opportunities. And so this is a lot different than the data that we see within our Portland area. And so we had to find ways to go ahead and inspire hope in individuals, as well as try to find ways to go ahead and partner with organizations that were serving this population. The amount of individuals that were coming into our community center that were experiencing geriatric symptoms seemed really high as well, whether that be incontinence, having issues with mobility, malnutrition because of their experience or living on the streets. And so we really had to go ahead and learn best practices on how to serve this community. Next slide. We also saw a larger increase or a larger need for individuals seeking support that were identified as being male. And it was a lot harder to go ahead and get female identifying individuals to engage in services. And I don't know if that was due to just more options or availability locally for individuals that identified as female, or that men were just seeking services more. And but that is definitely something that we were identified within our services. Next slide. What we were able to do though is help a lot of individuals through our community center, and we're actually going to go ahead and implement new data tracking systems, because even if individuals were not signed up for our services, they were still finding support with housing applications, food resource navigation, medical referrals, and basic needs. But from the individuals that did sign up for services, just in the short 10 months, we were able to go ahead and help 3 individuals access education, 6 individuals find employment, and 4 individuals find stable housing. Most of those stable housing came from our partnership with Oxford House. So shout out to Oxford House. Ed, you all are doing amazing work. And without you all, people in Josephine County definitely would be struggling. Next slide. So after we opened up our doors, we experienced some pretty big struggles, right? And, if I'm going to be honest with you, I thought that Grants Pass was kind of going to be a cakewalk, right? I'm like, okay, we're coming from Portland. I've dealt with Portland things. This is, we have the blueprint. We're going to be okay. But what I found out was that, Josephine County, for one, didn't have a baseline understanding of what a recovery center is. For 2, the lack of services that are needed for the community, right? And so being the only thing open from 2 to 10 for people experiencing instability and substance use, we found that everybody was coming to our center, whether they were an appropriate referral or not. And so it took a lot of outreach to our community partners to explain to them, hey, what is a recovery community center? What is the purpose of our drop-in center? And who should you be referring to services for us? And the other thing too was stigma amongst our immediate neighbors, right? We were having people that have basic needs that need to be met that were coming to our center, and close neighbors that were not happy with the foot traffic coming into our space. So it took a lot of time for us to go ahead and have conversations with them, explain to them what we're doing, that we are a solution to the problem. We're not exacerbating the problem. And that's an ongoing thing that we're trying to do. And I think it's going to be an ongoing experience with us. And so being able to go ahead and listen to their concerns, and then also explain to them, our safety protocols and the expectations of individuals when they are at our space and on the property. The other thing is that we're having a large population of individuals experiencing that housing instability. Oftentimes we have seniors that are coming in that have recently lost their housing. And so it's one of our immediate needs is to find housing for those people. We also had a lot of mental health crises when we first opened our doors too. It seemed like every other day we had somebody coming in some form of psychosis or mental crisis, right? And so, and not having a way to go ahead and refer them to a location within the county. And so oftentimes we would go ahead and have to call, options for support. And if they could have a mobile crisis unit, and if they didn't have an available person to go ahead and respond to the crisis, we would need to go ahead and call for police support. And we've really developed a good relationship with Sheriff Daniels and Scott Hyde at Parole and Probation, where they understand our services and they're here to support us. And they have taken a kind understanding to individuals that are in those sort of crises and helping them go ahead and get the medical support that they need. Currently, we did go ahead and hit a wait list of 3 weeks, but we have been able to go ahead and reduce that. So people are about 2 weeks out from being able to receive an intake. This does limit us with being able to go ahead and do the amount of outreach that we wanted to in more rural settings of the county. And so, one of our immediate needs is to try to get another peer support on the team, so that way we can actually go ahead and do targeted outreach versus just trying to go ahead and work off of a wait list. Next slide, please. We had some great successes as well, though, even though we did face some struggles. Within those 10 weeks, we were able to provide 391 hours of mentoring, 259 engagements with participants. So that's one-on-one participation with the mentor and the client. 8 individuals access treatment, with several of them being transported to Klamath Falls Transformation Program, which is an amazing program and has really supported us with being able to provide treatment or inpatient treatment services and then wraparound services afterwards as well. Oxford referrals and emergency lodging application support at the center was something that we're able to develop too. So if an individual comes in, we are able to go ahead and get the emergency application done with OnTrack, which is now Continuum Care. And we've also been able to go ahead and help individuals navigate the Oxford website, get their applications completed, and then schedule interviews with the local Oxford houses as well. And with reentry, working with Scott Hyde's team at Parole and Probation, we've seen a lot of individuals come out of prison, get a mentor, and then really be able to go ahead and execute their short-term and long-term goals. We have an individual that, got out of prison, was in their halfway house, and we were able to go ahead and assist them with finding employment. He actually has 2 jobs now, just got his license, and is just extremely happy. And then is saving up to go ahead and purchase his own vehicle. And this is an individual that has had consistent run-ins with the law, a history of relapse, that is finding that support system within his community, and comes to the center and enjoys the space when needed. And so it's really great to go ahead and see those success stories, and those success stories coming in just a short amount of time. Next slide. So what we're planning for the future, what we see the need is for outreach, an outreach team, housing, and being able to go ahead and expand our mentoring support and services. And so, that is, a dream at the moment. What we do fear, and I think that you all have been hearing this from, other funded programs that have presented today, every single nonprofit in the state is hurting in some way, right? We have we have reduced funding, and then the grants that we all apply for are becoming a lot more competitive due to that immediate need, right? And so the concern is what are we going to do after this funding ends? Building up this infrastructure within the community, it's a non-negotiable to go ahead and dissipate this after the funding goes. And so being able to go ahead and find out ways that we can go ahead and advocate at the legislative sessions, being able to go ahead and find out ways that we can go ahead and plan to fund already built programs, so that way, pilot programs and so forth don't just disappear. That creates a huge burden amongst the community, right? If we want people to go ahead and count on us, we need to make sure that we're going to be here long term and not just a flash in the pan, right? So we're looking for funding. We're looking on ways to go ahead and diversify the way that we fund the organization. And so what we actually will be doing and piloting up here in our Portland area is opening up treatment services, so we can become billable on one side of services that can go ahead and fund our non-billable services, to the point where we can be somewhat sustainable without 100% reliability on grants. And so we're trying that out to see, if that's going to be successful. But overall, if funding opportunities do come up, I think I just want you all to hear that it's really, really important to go ahead and continue funding programs that we're building up in the moment. We're developing staff skills and mentor comprehension. Everyone on my team is brand new. And so making sure that we're falling back on best practices outlined within research guides, within MACBO, making sure that people are following ethics. That way, our quality of services don't diminish. And so we're definitely leaning heavy into that. And then also expanding our project awareness. Now that people know that we're there, we got to inform people and continue to inform people of why we're here, right? And so explaining to them that our drop-in center is a sober environment. We're here to help people in the recovery, however they identify that, but we are here to go ahead and help people actively move towards completing and accomplishing their goals. And that's just going to take time and awareness. And so we're consistently out there talking to people. And then when we do get inappropriate referrals to our center, we're having conversations with those people, finding the most appropriate space for them to go ahead and access, and then finding out who's referring them to our agency, so we can go ahead and provide clarity statements to them as well. Next page. Okay, yeah, that's all I have. Thank you.
That was wonderful and so complete. Amanda, thank you so much. Do folks have questions for either Ed or Amanda? Julia.
Thank you. Great presentations. Thank you very much. Thank you for all you do. I just have a question on the Oxford House. I'm curious how much time it takes to stand a house up from when you get, get a house. How long does it take for you to get whatever you need to get it filled?
So I would say that filling it is really not an issue. It's building the infrastructure around it, right? Building the foundation. I would say the average is about when we open new houses, I tell my team that we need to plan on 6 months of being there for every house meeting, and being there. So anywhere from 4 to 6 months. The way the model works is that houses belong to chapters, chapters belong to the state. So it's a whole group of volunteers that sort of surround each other, right? So especially in new areas like Tillamook, the team member that I had here just left like a few days ago. So, and that took about 4 months. So,
Lori.
Thank you. Thank you both, Amanda. I'm so glad there's a resource like yours in Southern Oregon. I know it's really needed there in particular. I have a question, Ed, about you mentioned, immediate expulsion. Is a bed held, or how is a person prioritized to get back into the house if they complete successful treatment? What happens after that for that person in relationship to Oxford House is my first question.
Sure. So what happens after is, because because Oxford House is a self-supporting model, right? They do need to fill the bed. However, if people choose to surround themselves still within Oxford House, just because you can't live in that specific house after you relapsed doesn't mean you can't be surrounded by the Oxford House family, right? And, is a bed held? No. Do they generally get in quicker into other houses or that same house? Yes. So there's no definitive yes, we can hold a bed because the house still needs to function financially.
Got it. And then my other question, maybe I missed this. Do you own some houses? Are they all rentals? Does the entity that is Oxford House sort of act as a master leaser for rentals? How
Yeah.
does that part work?
We do not own. Oxford House does not have any assets, so we do not own any of the houses. It's all all our houses are rented through private landlords. And we have a system that we use that is a lease, that each house is its own little entity, right? So each lease is specific to that house.
But it's sort of like a master lease. Oxford House holds
Yeah.
the lease and the individual residents pay the expenses.
Oxford House, let's say in this case, Oxford House Tillamook holds the lease.
Right.
The individual residents are Oxford House Tillamook.
Sure. Got it.
Yeah.
Great. Thank you.
Yeah.
Rick.
And this is Rick Trelevin from Central Oregon, and I'm embarrassed that I don't know this. I should know this, so I'm going to ask a stupid question. Does Oxford House what's Oxford House's approach to people currently on medication-assisted treatment?
We absolutely take any path to recovery, right? So we have no stance other than if it's prescribed to you, then any pathway is okay with Oxford House. Now, 15 years ago, that may have been different, but we've been accepting for a very long time, longer than I can remember. And that's a myth that's out there still, and it's odd to me. So.
Okay. Last call for questions. Okay, April.
I'll be quick. I appreciate both of these presentations, really informative. I think one of the challenges this board has is the one-time funding nature of the money that we have. And so it's really both heartwarming and heart-wrenching to hear the successes of programs that we're not sure how we will be able to sustain in this avenue. However, most of us are connected to other parts of the systems of care, and it's always good to learn more about what's successful and what's working. So I appreciate these opportunities to hear from you all. I have a question for Amanda about the sort of change in mission or population, the cultural specificity of your program. That must have been a kind of a culture shock for your team, for your staff, for your organization. And it sounds like you adapted really well at figuring out how to meet the needs of the community you're moving into, which is not an easy feat at all. So, big props to you and the work you put on in the ground and with your team. I guess I'm wondering if there are still elements of cultural specificity that you can provide. It's not like Southern Oregon doesn't have queers that need help. And so are you able to provide those spaces and meet the needs of different populations that are sort of coexisting? Obviously, you've adapted to the needs of people coming in through the door. And then I think the second part of the question is around the relationship that sounds more almost case management level of care instead of recovery mentorship. Are you working with the county to and or other resources to help, not necessarily case conference, but really help people get connected to what they need, that it can't all be housed within a recovery mentorship relationship? So sorry, big question, but
Yeah, no, thank you, April. And so for your first question, yes, we have been able to go ahead and have cultural specificity within the LGBTQ plus community. We naturally attract who we are. And so within our staff, half the staff identifies within that population. And then we've also seen increased amounts of individuals participating at our center that identify in such a manner as well. Within our onboarding practices, we go ahead and provide education on LGBTQ plus 101, as well as our best practice guide that we developed through a DACM study as well. And so we are still applying our values of inclusivity and understanding within our culture down there as well, and then reaching out to local organizations such as the Rogue Community Center or Rogue Community College and so forth, where there are like higher populations of LGBTQ plus individuals, to get them participating within our services or within our space too. And then for your second question within the case management, and so yes, and so oftentimes when we have an individual that has a lot of needs and maybe isn't in informal services but engaging in the center, what we do have is our front desk individual that's able to go ahead and support them with referrals out. And so oftentimes we're referring individuals to other programs that have the ability to go ahead and provide immediate case management, such as the MINT program. ADAPT has, some peers on the floor, that are funded through Measure 110 funding. And then we also have connections with the Sobering Center. And so we're even doing transportation from our specific location to the Sobering Center at times. And so we have kind of developed a network of support where we can't go ahead and support someone specifically because of our capacity or because it just doesn't fall within our mission, we are able to go ahead and connect with other resources. The hope is that we would be able to go ahead and develop an outreach team that has a case manager embedded in it. So that way everything would be in-house and we wouldn't need to go ahead and do so many referrals out.
Thanks so much. Okay, I think that wraps up this portion. Ed and Amanda, both, thank you so much for coming today and for being so thorough with your presentations. We really appreciate it. And April, thank you for summing up what I'm guessing are the thoughts of most of the board right now, that we're funding really amazing things and we need a lot more money than we have to keep funding them. So on that note, Zach, I think is going to take us into retreat planning to help us figure out how to tackle the next round of funding.
Absolutely no pressure there, right? Okay, so I'm just going to share a slide real quick. So, as we know, our retreat is coming up on January 14th, and we just wanted to take a few minutes today to talk a little bit more about what you all would like to see at that retreat. I know we've talked about it a little bit over the past couple meetings, but just really wanted to hear from all board members and take a step back and think about what does success look like for this retreat. So to that end, I do have a discussion question. So indulge me a little bit here. We're going to go into a time machine. Pretend that you are leaving the retreat at the end of the day on January 14th, and you're walking out of the building feeling good about how the retreat went, and you feel it was well worth your time. What was accomplished during that retreat to make you feel this way? And in order to allow everyone to participate, I am going to ask that we write our answers on this form that I'm dropping in the chat. So if you all could just take 5 minutes, think through this, think about what you would like to accomplish in that retreat, because this is really for you. This is about what you want to see happen as you start planning your next round of allocations. So let's just take 5 minutes. We can come back around 12:31 or 12:32 and go through those and have a discussion. Thank you. All right, just about 30 seconds left. So wrap up your responses and then I'll share on the screen. All right. Thank you, everyone, for taking some time to step back and think through what you would like to see accomplished in that retreat. Looks like we have 10 responses. If you haven't submitted yet, feel free to do so as we discuss. But I am going to pull up the responses, walk through them real quick, and then we can have a quick discussion about anything that stood out to people or if there's anything people would like to add. All right. So what we're seeing here, we have summarize and review accomplishments, review current and future budget, reaffirm and explore AOD landscape and priorities for funding, set targets for the next 2 to 5 years, and establish those in-person board member relationships. We want a clear understanding of the schedule of settlement dollars coming to the state, a clear breakdown of programs who were granted dollars and how much, and would like to know if the board will continue to support programs already granted money or if it goes to new programs for each round of funding, and then identify communities with the greatest unmet need. We came together to acknowledge the current challenges we're facing as a state, share what our biggest hopes, fears, and funding gaps are for our system of care in the state and local level, identify what worked well in the last allocation process, and clearly articulate our priorities for the next round of funding. So already seeing a lot of similarity in that wanting clear articulation of what priorities are moving forward. Again, clear direction for how we will allocate, mechanisms for people not currently connected within the system. So again, those underserved communities. We have discussed and thought about how to correct for the needs and sustainability of the programs we are supporting. And that's something that's come up frequently in board discussions over the past few months. We have consensus on how the board will allocate the next round of funding, including a general idea of the types of services and strategies. We have more personal connections to other board members and celebration of successes so far, and that's something that an in-person retreat is going to be great for. A clear sense of if funding priorities have changed and how and why, and then mapped out a plan for the year's meeting themes or topics. So sort of a meeting arc and schedule to plan how we're going to tackle our work next year. Better understanding of the team members and their knowledge and backgrounds. Again, that personal connection, knowing each other a little bit more, and then agreement on the path for the next steps in decision making. Again, a note about strategic philosophy and planning for that sustained support over time over the next 10 years. And then a shared collective vision of priorities for the next round of funding allocations. And once again, getting that opportunity to meet people in person and feel more connected as a board. So those are some great responses, and I'd say they align with what you all have shared in the past and what we're sort of thinking about as we plan the retreat agenda. We definitely want both that opportunity to really just get to know each other in person and really think strategically about what our next steps are as a board. Having read through that, are there any particular items that people would like to flag or discuss or things that you particularly agree with that you heard? Does this list generally seem right to folks? Seeing some head nods. Anything missing that we should also consider talking about during the retreat? You got it all out on paper? Nothing else?
That is one thing.
Yeah.
I didn't see a disco globe on there.
Okay. I like that idea.
Maybe one of those.
Uh-huh. Can do.
That's for the after party.
There we go. Love that. All right. Any other missing things?
This is Joanne. I just have a little bit of concern about us not being in the position of of setting all these goals and priorities and then having emergent issues arise that much as we did this last year, that we just simply were not able to fund. So I'm wondering if it might be possible for us to, and I'm not asking for, for RFPs to come in, but for us to get out to the community that we will be doing this kind of planning and somehow get some of those emergent issues sent to us or brought to us in advance of our retreat. And I don't know if that's, I'm making any sense about that, but I think some of our state agencies may know where where they are and where they may be needing funding, and some of our other providers may know as well. So it kind of falls into that. Will we be funding projects that we are currently funding as well?
Thanks for that question and comment. Yeah, I'd say I'll open it up to any other responses too, but as board members, definitely taking opportunity before the retreat to talk to different constituents that you serve or work with could be helpful in that regard. And then I'm sure if there's particular state officials or people that we'd like to reach out to, we can make that happen. I don't know, Lisa, if you have any thoughts on that.
Oh yeah, we can make something like that happen, and I'm sure Annalise has a lot of insights given your recent road show, so I'm sure we could put something together.
Excellent. All right, so we are just about at time for this discussion. Thank you so much for sharing your thoughts with us. We'll definitely read through those again and make sure that we're incorporating all of that into our retreat agenda. And then make sure to share that agenda with you in advance so you have a chance to provide any feedback on that. Next, we are moving into public comment, and I believe we do have someone signed up, so I'll turn it over to Annalise to review the rules.
Thanks, Zach. So I'm just going to read this little disclaimer. I think we only have one person for public testimony. The Opioid Settlement Prevention, Treatment, and Recovery Board welcomes and appreciates public testimony. We will do our best to not interject during public testimony. We will, however, bring it full into our awareness, understand it as an important consideration for our work, and listen with careful attention and respect. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Opioid Settlement Prevention, Treatment, and Recovery Board itself, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and if that doesn't feel like enough time, we encourage you to provide written testimony to share with the board. So keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that you conclude your presentation when the timer is complete. If public testimony includes questions for the board, co-chairs, or OHA, please provide your contact information so that we can respond following via email. And with that, I think we have, is it Dr. Schwartz?
Yes. And I'm going to try to share my screen here. I'm not the most, okay, share. One participant, multiple participants can share. So I don't know whether that's going to work or not. I'm just going to talk then. Forget it.
Dr. Schwartz, I made you co-host. Did
Oh,
you accept that? You should be able to share.
I don't know. I'm not that
Oh, I'm
technical.
sorry.
I'm sort of in, never mind. I don't want to waste my time.
Okay, I haven't
Just to
started
sort
the
of
timer
introduce
yet.
myself, this is not the last time you're going to hear from me. I have been on the front lines of medicine my whole career, okay? ER, urgent care, and for the last 15, addiction medicine using Suboxone. Suboxone was a real breakthrough, and I've sort of been there and I've seen amazing breakthroughs in my career. And I'm trying to introduce you to something called transcranial magnetic stimulation, which I believe is going to be a major breakthrough, and I'm not the only one. And I've assembled a pretty interesting group, and we've spent about a couple $100,000 of our own money to get this pilot going. We're doing a pilot at Another Chance, which is a recovery place. And I should also introduce that I founded Recovery Works Northwest, which has 4 outpatient clinics and a detox, 16-bed detox. And following these people after, I get so frustrated. The relapse rate after detox is like 40% within 3 weeks or 30%. We don't even know the data. And we really believe that TMS could make a really difference in increasing people's cognition and decision making. And so we're starting a pilot in January, and we think it's going to be we think it's going to be successful. And if it is, we're going to need to really do some serious dose response. Now, I don't expect this board to fund this whole thing, but we're putting another 200 in, and we're trying to build a coalition because we think for maybe a million two, maybe a million two, we could do some serious within 2 years dose response stuff. It should be a standard of care. It will be, I think. But as an example, if anybody knows anything about TMS, it's been huge for treatment-resistant depression. And at Stanford, they've been actually able to show that you can get people non-suicidal in 3 days in the hospital. And this was like 2000, but there's a just broken part of our medical system where stuff in academia takes so long to get out to clinical practice that we
Dr. Schwartz,
really,
I'm sorry we're at time if you don't mind wrapping it up.
uh, well, like I say, it's basically I'll come back and do it. I'll send some printed stuff. If anyone is interested in this at all, my contact information was in the handout. I'd be happy to. I'm talking to anybody. I don't know whether this is the right board or the right place to ask for money, but it seems like you've got a lot and nobody else has any compared to what academics and Medicaid and all that. And our practice is 80% Medicaid. So I think we really are in a position to make a difference. And if we could just reduce the relapse rate, talk about prevention of these people out of detox, that's where I mean, there's 50% of them relapse within
Thank
2
you
weeks.
so much, Dr. Schwartz.
Yeah,
We
all right.
really appreciate it. Lisa will pass on the written slides to the whole board. And I think I'm passing it over to Jenny to talk about next time before we leave a little early today.
Yes. Yeah, exciting that we can end a little bit early today. It was great hearing from all of the presenters, and we have our next meeting scheduled again this first Wednesday in November, and we will be hearing a few more presentations from grantees. So to prepare us for our meeting in January. So we're excited about that. And I think that of course, if you have any questions for any of the presenters that you weren't able to ask today, you're welcome to go ahead and reach out to them. Their contact information is included in their presentations, which are already available and were a part of your packet. Or if they weren't a part of your packet, they will be available online soon. So yeah, I think with that, we can go ahead and say thank you everybody for coming.
Thank you.